Good afternoon. Welcome and thank you for joining us for today's webinar, When Does Mental Illness Lead to Disability? Sponsored by Personalized Prescribing, Inc. Personalized Prescribing is a Canadian pharmacogenomics company with a focus on psychopharmacology. Their specially trained psychopharmacists work with patients both on disability or actively at work and their physicians to help optimize their antidepressant treatment. I'm Kristen Dougal, Director of Meetings and Events for Benefits and Pensions Monitor, and I will be your host today. Before we get started, I have a few housekeeping items to review. This is an example of the attendee control panel. You should see something similar on your own computer screen in the upper right-hand corner. Use the orange arrow to open and close your control panel. Use the audio pane to select your preferred audio. Choose computer audio to use your computer microphone and speakers, or choose the phone call option to use your telephone and dial in using the information provided. If you have questions for today's presenter, please type them into the question pane of the control panel. You can submit them at any time during today's session. We'll be collecting them and addressing them during the audience Q&A portion at the end of the webinar. Use the handouts pane to download the available document. You do have access to download the speaker presentation slides anytime before the session ends today. Please note that all attendees are in listen-only mode as we'll be recording this webinar. It will be available to view on our website in the next few days. To begin, let me introduce you to our presenter. We have Mark Faiz, CEO at Personalized Prescribing, Inc. So let's jump right in. Mark, I'll hand it over to you.
Thank you, Kristen. Thank you, ladies and gentlemen, for joining me this afternoon. So my topic today is, when does mental illness lead to disability? And, you know, it's not rocket science. I guess the most important, I guess the most important thing that I can say is that when treatments fail or are not adequate, and mental illness continues to hound the person, it ends up leading that person to disability. And you may say, what are the treatments? And we all know what the treatments. There's psychotherapy, which is necessary in my opinion, and it works quite well when it is focused. And of course, there's medication. And the problem is, and I'm going to focus today on medication because that's our business, and medication, unfortunately, in the mental world, mental illness business does not work readily like most other medications do with other conditions. Mental illness is very unique. It's very unusual in that it's the disease of a brain, and honestly, humanity does not understand the brain well at all at this stage. We're finding out, we're learning, and more science is digging deeper. But the problem is, you know, we cannot take a sample of the brain that readily, send it to a lab so it can tell us what's wrong with that brain. And as a result, if we cannot diagnose specifically what's gone wrong, how can we prescribe the right medication? And apart from that, medication is so complex because the brain is so complex, and that's where failure leads to this depression, and then failure leads to disability. Today, I'm going to take you through a very brief journey of two people, one Chantal and the other is Oscar. Both these people have very similar symptoms. So Chantal has reported she's got loss of pleasure, low mood, low interest in things that used to be pleasurable, lack of concentration, some anxiety, and Oscar basically is feeling the same way. a persistent feeling of sadness, loss of interest, irritability, sleep disturbance, and feelings of worthlessness. And these are typical signs. Now I'm going to take you, they both have the same physician, and we're going to be a fly on the wall of that physician. So let's see what happens. Both of them go to this physician, and the physician basically hears what we just said about the symptoms, and the physician begins to think, oh, in Chantal's case, I'm thinking this is depression and anxiety, and in Oscar's case, it's depression. Nevertheless, the doctor makes a few notes of the questions that they were asked. Notice there's no clinical testing ordered. So we go to a doctor, he orders a blood test, an X-ray or whatever, not in this case. And the doctor readily prescribes exactly the same medication because the guidelines for these types of symptoms is the first line SSRI. SSRI stands for selective serotonin reuptake inhibitor. And there was no need for a follow-up appointment or anything like that. But the doctor does say, look, start with half the dose, and then after a week, go to the full dose, and then let me know if there's any problems. So 2 weeks go by. They both have a bad experience. Chantal is experiencing, she's still down, no symptom relief, and same with Oscar. They both call the doctor, but the doctor assures them, look, mental illness medications don't work readily. Stay on the medication, stick with it. 4 weeks after, Chantal begins to report that she's feeling a little relief, and her side effects that were bedogging her are beginning to go away, while Oscar is not reporting the same thing. He is not feeling better, he's feeling even worse, he thinks, and so on. We now begin to diverge. And 8 weeks after, Oscar is beginning to report that she's feeling much better. Her side effects are almost gone. She believes she's as good as ever. Now remember, in both cases, they're still at work. And in both cases, they're both seeing psychologists. And in the case of Chantal, there's a big difference. In the case of Oscar, it's not working. Oscar visits the doctors again. The doctor simply, after 8 weeks, increased the dose and adds an adjunct medication to help with anxiety. 12 weeks after, Chantal is back to her routine. She's basically normal. She's taking the medication, but not Oscar. Oscar, it seems to be getting worse. And at that stage, the doctor says, look, I think the medication might not be compatible with you, Oscar. Let's try a different medication. Let's go to 6 weeks after. Forget about Chantal, she's back to normal. Oscar is now experiencing different side effects. Remember, he's a different medication. He tapered off the old medication over the last couple of weeks, started the new medication. You know, he's not feeling any better, and he's actually experiencing new side effects that were not there with the first medication. The first time Oscar is thinking, I can't continue to do this. I don't know. I'm not concentrating at work. I'm not able to do my job properly. Maybe I should claim disability. 6 months after, Chantal is dancing. She's happy. Oscar is now on disability. And unfortunately, the doctor, his family doctor, has now, quote unquote, referred him to a psychiatrist but the appointment is set for 5 months from now. So we're just going to sit there and wait to see a psychiatrist. So, ladies and gentlemen, what caused Oscar's disability? It's not the mental illness, because in Chantal's case, she didn't lead to disability. It's the failure of antidepressants. So why did Oscar's antidepressants fail and not Chantal's? Genetic variability. In the pathways of these depressants within the brain, there are different genes that are responsible for absorbing and clearing the blood within the actual clearing the drug within the blood system. Then the drug needs to enter the brain and cross the blood-brain barrier. And there are genes there that might be too active to allow the drug to get in. And finally, when you get to the actual brain receptors in the brain that are the target of the drug, these brain receptors better be the right variety, otherwise the drug might fail. So the drug might fail at any one of these 3 stages. And, you know, it's simple. We have variations sometimes that actually cause us to fail drugs. And in this case, Oscar has many of these variations. Now, to demonstrate this, I'm going to describe what this graph is. So the graph basically is taken from the 1000 Genome Project, which is the statistical project in general about genetic variations and the number of people that might have them and so on. And we took 1,000 human beings and we took the specific variations that could make an impact on antidepressants. And what we found from these statistics, we found that almost no human beings out of these 1,000 people had 0 variance. This here, 0 variance, nobody had them. But when it comes to 1 variant, there was about 10 people that had 1 variant. And then you continue, 50 people had 2 variants, 110 people had 3 variants, 150 people had 4 variants, and 130 people had 5 variants, and more variants. But then at that stage, we begin to have less people having more variants. Now, this circle here, or this oblong, if you like, are the people that have so many variants of the specific genes that we looked at for antidepressants, such that we now, the likelihood of failure on these depressions begin to be higher and higher. Oscar, I suspect, is in that oblong here. And now let's talk about mental illness, disability, and was it avoidable? And I can tell you without a problem, absolutely. If in fact there was a way that there was a test that can tell the doctor that Oscar's has a lot of variability and his antidepressant, the first line of antidepressant, was not going to work, and forget it, try something a little unusual that can address his situation, then Oscar would have gone through the exact same journey as Chantal and would not have been on disability at all. So, and that test is pharmacogenomics, ladies and gentlemen. They are available, and this test can, in fact, identify the right medication with least side effects at an early stage. And if that had happened in Oscar's case, his spiral would not have happened and he would not have been on disability. Now, there's many different pharmacogenomics tests out there, both in Canada and the US. And for a pharmacogenomic test to work, remember I talked about the 3 steps. Antidepressants must be able to be absorbed into human body and absorbed into the blood, and very importantly, must be cleared from the blood readily, so that when you take the next tablet, it doesn't end up with more and more drug in the bloodstream that could become an overdose and therefore toxic. Having achieved that first step, whereby the blood has enough concentration of the drug in it, now we need to get the drug into the brain. And at the brain, there is a particular protein called the blood-brain barrier. It's called the ABCB1 gene, or the PGP protein. And this protein is really meant to protect the brain from any outside substances. And of course, the drug is an outside substance. And this PGP protein looks at the drug and says, who the hell are you? What are you doing here? And tries to kick it out before it gets into the brain. So it's very important that we determine whether that particular patient has an overactive blood-brain barrier or not, so that we can then prescribe the drug that actually is not recognized that readily by the blood-brain barrier, if the blood-brain barrier is overactive. So it then can sneak in. And then if you achieve that second step and get into the actual brain receptors, there are very specific targets to these receptors, to these drugs, and these are specific receptors. And if that receptor is deleted, for example, and sometimes they are, well, the drug doesn't attach to anything. So the drug is absolutely a waste. It needs to have the right receptor and the right quantities so it can attach to it and do its job. This whole thing I just described is easily described. But then when you look at all the different genes and the receptors and the different variations and so on, you really need to have a specially trained pharmacist that can understand the implications of every step and what the drug may and may not do and so on. And as a result, the pharmacist can look at the total picture and produce one clear, concise report to the doctor that the doctor can use and move to the right medication or a different medication if that's the case. We, personalized prescribing, check all these boxes. Our results, ladies and gentlemen, have been exceptional. Now, having said that, I will tell you, this is the tough neighborhood. I'm not going to tell you, oh yeah, we make miracles. We can really turn lives around. But sometimes about 30% of the patients, while they're happy with our work, are what we call treatment resistant. And this is a crazy thing for me to say, but I'm going to say it. There are no drugs that would work for these people. It's that simple. These are treatment resistant human beings. And you know, like, we don't abandon them. We don't tell them, let's go away, there's nothing I can do for you. We try combinations of drugs. We try higher doses. We try all kinds of things. But I tell you, they're a challenge. Having said that, you know, our success ratio is huge. I invite you to go to our Google reviews and read some of the people that talk about us. We've got every single one of our reviews are 5 stars. 4 stars, no, 5 stars, every single one. So if you want to avoid mental illness, disability, you got to go to pharmacogenomics. Kristen, I'm done. You want to take over?
Excellent. Yes, thank you, Mark. I appreciate you taking the time to share your knowledge and insights with us today. Once again, I'd like to thank our sponsor, Personalized Prescribing Inc., for their hard work and support leading up to today's webinar. We will now open it up to questions from the audience. So as you can see on your screen here, again, if you have questions for Mark, please type them into the question pane of the control panel. So Mark, our first question is, why do antidepressants take that long to become effective?
That's a really good question. Well, there's a lot of technical stuff here, and I'll try not to get too scientific here. It's not about the antidepressants. So antidepressants attempt to raise the neurotransmitter level within the brain. So if you're on a serotonin reuptake inhibitor, you're trying to get the serotonin level in the brain to be higher. Now that doesn't happen that easily. There is the first thing you need to do, or the drug does, is, if you like, it hits a specific serotonin autoreceptor on the head repeatedly to try and get it to stop slowing down the neurotransmission of serotonin between the presynapse to the postsynapse. And that doesn't happen that easily. You've got to keep on, and you do that by keep on pushing the receptor, and the receptor opens up, but then it closes, and then you keep doing it until what we call you desensitize it. When you desensitize it, it's almost like a brake that has lost its shoe. It gives up, and it allows the serotonin to start flowing properly from the presynapse to the postsynapse. That takes 3 to 4 to 5, 6 weeks, depending upon the different genes in the serotonin system. I'm sorry if I had to go too deep into the science, but
No problem. Thank you. And the next question here, do you think you could speak on maybe the value of cognitive behavioral therapy as well? Do you have any thoughts on that?
yes. So honestly, I will admit that medication alone and us alone just sometimes is just not enough. You need to have psychotherapy. Now, I'll tell you why, and very specifically what a psychotherapist should be focused on. Let's go back to the beginning, or the cause of the depression to start with. The cause of the depression is some genetic variants in the brain that predisposes that patient to depression, but also a chronic stressor, whether it's at home, at work, financial, or any kind, but chronic, not a big event, but a chronic, continuous, low-fire event that stays there and stays there. That eventually begins to dysregulate the neurotransmission systems so badly that the patient becomes depressed. Now, what do we need to do? Imagine, if you like, that you're in a car, and the car has both a gas pedal and a brake pedal. The gas pedal is basically the chronic stress. You're applying more gas, and the car is going faster. The brake is the antidepressant. You're applying the brake so it can slow the car down. But before you can slow the car down, and at the same time, you need to lift your foot off the gas pedal. And that's where the psychotherapists need to be concentrating on. They need to talk to the patient about, what are the chronic stresses that you might be going through. Now, of course, they don't ask these blunt questions. They sort of lead the patients through the journey to sort of say, tell me about it. What is bothering you? And then we need to identify that chronic stress. Now, I want to stress something. Quite often, the chronic stressors are not in the patient's mind that important. Well, yeah, I've got this mortgage problem. I haven't paid my mortgage. It's big and I can't afford it really. I constantly go in deeper in debt and so on. Yeah, but it's not a big deal. I mean, I got bigger problems. Well, that could be the problem. So you need to actually reach that chronic stressor that is the gas pedal. And you need to, the next step is that psychotherapists need to say, look, how do we cope with this? How do we manage this? We need to focus. This is the problem. Now we need to cope with it. And if that happens, and at the same time, antidepressants are working, the person is feeling better.
Perfect. And have you ever encountered situations where physicians have been reluctant to implement the suggested medications provided in your pharmacist report?
Yes, unfortunately, in our case, it doesn't happen often, but we do encounter physicians. I don't know why, sometimes out of arrogance, sometimes out of ignorance, because they simply don't know enough about pharmacogenomics. And so they sort of, I don't want to, no, who are they to tell me what to do and so on. But, dear doctor, you've already tried one medication, it failed, and so on and so forth. Look, they will not get it right unless there is a genetic test that can tell them whether the patient will respond or not. Yes, we do get them. Thankfully, though, we found out that the most important thing for a doctor is to understand that that doctor is very busy and not to give them a report which is 30 pages long. They just want a one-pager that says, this is the right medication, signed by a proper certified pharmacist, and then the doctor does make that change. So part of the problem is doctors are lazy or don't have the time, but the other part, some are arrogant. And I'll tell you, we've had doctors that have said to their patients, forget it, I'm not even gonna look at this. But of course, 6 weeks after the second medication fails, the doctor says, you know what, let me see that stupid report that these people gave you. And then they put them on the right drug and things begin to happen.
Great. And can side effects be determined from the genetic profile?
I'm not hearing anything. Are you there, Kristen?
Yeah, did you hear me? Can you hear me now? I said, can side effects be determined from the genetic profile?
This is awkward.
I can hear you, Mark.
I'm going to tell you, maybe Kristen is talking, but I'm going to tell you a little bit about our next webinar, which might be of interest to some of you. We're going to take you through a calculation that would calculate what the cost of mental illness in actual dollars in the workplace and a return on investment, possibly.
Excellent. Mark, can you hear me? Well, unfortunately, that is all the time that we have for today. If your question was not answered, I will be passing them along to the speakers and sponsor company, and someone will follow up with you directly. If your question, I want to thank everyone for joining us today, and a big thank you to our speaker and, of course, Personalized Prescribing Inc. for sponsoring this webinar. We hope that you leave us having learned some new and valuable information. At the end of today's webinar, you will be prompted to answer a short survey. We encourage you to give your honest feedback to help us with future planning. Have a wonderful rest of your day, and please stay safe, everyone. Thank you.